All right, so I am Cyrena Galuga. I am the Director of Operations for the Preparedness and Treatment Equity Coalition. And today we're with another one of our grant awardees. Um, and I would like you to introduce yourself, and then we'll just talk about the work that you plan on doing.
Great. So my name is Andrew Anderson. I'm an assistant professor at the Tulane School of Public Health and Tropical Medicine. I'm in the Department of Health Policy and Management, and super excited about this program and this grant. I have a team of researchers who I'll be working alongside for this within Tulane, as well as at the University of Southern California and Columbia University.
Okay. So what do you research in general, sort of like in your daily life?
Yeah, so all of my work really focuses on issues of access and quality within the healthcare system. And it comes from an equity lens. So I'm really interested in the outcomes for people who are from historically marginalized backgrounds. So that includes people from racial and ethnic minority groups, but also people who are sexual and gender minorities, people with disabilities. So those are the populations that I focus on a wide variety of outcomes.
What's your educational background? How did you come to this area of research?
So I'm a health services researcher by training. So most of the questions in my field focus on access, quality, and cost. I came to this research interest from working early in my career in supporting academic medicine research. So through that, I was exposed to quality measurement and improvement on the ground in like hospital settings. And over the years, I've had the opportunity to work with different organizations that are focused on quality measurement. So the first was the National Quality Forum, where I worked on projects to endorse measures. So looking at the scientific rigor of performance measures and evaluating them and nominating them for federal programs like Medicare. And those measures are used for tracking national performance, tying, improvement to payment in the healthcare system. I've also worked with the National Committee for Quality Assurance, very similar name, but very different organization, which does quality measurement for health plans. So that's the measure development side. So from the policy to endorsing and getting measures into programs to measure development, all of that kind of informs my research agenda as an academic.
Okay, so I imagine then in doing that work, it's looking at sort of assessing and measuring the quality of healthcare and different communities' access to healthcare, sort of where you found this gap, which led you to the proposal, in that we don't really have a great way of quantitatively assessing equity within the healthcare system. So why don't you talk a little bit, you had a very interesting proposal, and I'll admit I had to reach way back into like statistics to remember all of the equations. So I think it would be really great for you to kind of work through what you plan on doing and perhaps explaining how you derived this formula.
Sure, yeah, I can give you the brief origin story of this. So this sort of starts with this idea that, there's this really famous report that came out like 20 years ago, Crossing the Quality Chasm, which outlined recommendations for the healthcare system for improvement. And I think there were 6 different recommendations or around that number, and equity was always one of them, but it's something that I think has been left behind, partly because there haven't been a lot of incentives to measure it, but then also because of the difficulty of measuring it. I think, as you probably noticed in the proposal, there are some like empirical questions, but then there are also some deeply like philosophical questions about what do we really mean by this, and like what is it actually, are we actually capturing equity? And a part of this is taking, and from my perspective, taking either developing or leveraging existing quality measures and re-specifying them in a way or stratifying them in a way so that we can identify these gaps in care. And there's a lot of differences in opinion about how disparities should be measured, how inequities are measured. If we're actually trying to get at health equity, which is more of like, the leading definition is like, everybody has a just and fair opportunity to live a healthy life, which is a super, high level definition that encompasses a lot of things. This measure is even more specific than that, and it focuses specifically on healthcare. So this is a healthcare equity measure, and then it focuses more on preventable hospitalization. So I think that I argue in this proposal that, preventable hospitalizations it's a population health measure. It's a measure that's been around for a long time. It's a part of the Agency for Healthcare and Research and Quality's kind of core set of measures. And it's over time demonstrated itself to be a reliable measure at the population level. So the idea behind this project is to take that measure, which is more of, even though it captures hospitalizations at the hospital level, right? It's more of a measure of the quality of outpatient care, because it's hospitalizations that would be prevented if a patient, in this instance, and there's a whole set of them, but heart failure was the one that we chose for this because of it's leading cause of death, very expensive disease. People from racial and ethnic minority groups are disproportionately experiencing hospitalizations related to heart failure, as well as deaths for excess deaths related to heart disease. So the idea was to pick this measure, which disproportionately impacts these populations, and re-specify it in a way that can capture some of these differences, and create a score that we can say how well a individual health system or hospital may be doing. And that really is, again, the quality of the outpatient care in the hospital's catchment area or the health system's catchment area, how well that they're being served. And it's to encourage health systems and hospitals to collaborate with public health agencies, with the outpatient providers that they already work with, to help to kind of prevent these hospitalizations, right, and track them over time. So I should have started out from the outset. So this measure was initially developed and implemented in the Sutter Health system in Northern California. There's a team there that they kind of came up with the prototype. They implemented it in their health system. I think there's 22 hospitals that created dashboards based on this index. And so the idea behind this is to take that, adapt it in a way that other health systems could use it, validate it, so that people working on equity in health systems can have a measure that they say, they can say is that it's reliable and valid. So the big part of this project is looking at first the reliability of the measure. So in what circumstances can it be calculated in a way that we can trust? And that has to do with distinguishing. This kind of gets into the methodological parts of it. Its ability to distinguish between hospital differences and within hospital differences among the various populations that are included in the measure. And then also looking at the validity of the measure. And there are a variety of ways to assess validity. One could just be face validity, which is, we have a team of experts that come together and say, yes, it's measuring what it purports to measure. But then what we hope to get at in this project is more empirical validity, which is to look at the association of this score that comes out of this index and the quality of outpatient care, so that health systems that adopt the measure can say, okay, we know that if we improve outpatient care in our service area, that we can improve our health equity scores, and specifically within these populations that are being highlighted in the health equity index. So Generally, that's the first set of aims around the in this proposal is to validate that measure, or assess the degree of validity, because you can never have a fully valid measure, right? There are other things that it probably will be picking up. But then the second part is where we want to look at the impact of the COVID, kind of leveraging this recent catastrophe to look at the sensitivity of the measure to change. And this is another way to assess both. It's two aims, assessing the validity of the measure, because what we would expect to see is probably greater inequities based on what we know about what happened during the pandemic, related to the physical distancing procedures that were implemented nationally. And then we would expect to see some changes either up or down. And that's really to assess the sensitivity. But at the same time, we'll also be assessing what was the impact of the pandemic on health inequities for preventable hospitalizations related to heart failure for the Medicare population. So all of it is really tied up around assessing the validity of the measure, but a byproduct of that will also be assessing the impact of the pandemic.
Okay, so what data sources will you be using in your research?
So that's what made this program super fantastic, is that we'll be partnering with Millman to access the full Medicare fee-for-service population, their claims. And the reason, having Millman as a partner will allow us to fast track this work in a way that we otherwise wouldn't have if we were to do this on our own, through all the data acquisition and the use agreements and, trying in an academic setting, trying to work with grad students, so all of that, it will allow us to kind of do this on a much quicker timeline than we otherwise would have been able to do. And I think it speaks also to the urgency of having these measures out there. And taking these steps to identify measures that we can potentially use.
So how have you found it working with the Millman team so far?
So we had a call with them a couple of weeks ago. I mean, they're really great, collaborative. They really reassured me that, we'll be able to work on this more aggressive timeline. So I feel really confident. And then having access to their programmers and analysts is top notch. So it's very, I'm excited to work with them. They're a really congenial group.
Yes, I remember from the call that I sat in on that their timelines are completely different from academia. They're like on the order of like weeks and months.
I know.
And like academia, we're like, oh, we can have this done in like maybe 2 years or something like that. Yeah. So I mean, I'm really glad that they're working with them so far has been a great experience. And that's one of the things that we really wanted to do with this grant, is that we know that data access can be in a lot of ways one of the most expensive, if not the most expensive part of a budget for health services researchers. And so kind of taking that out of the equation would make it a lot easier for teams like yours to just kind of jump into this and really have access to the data resources that you need to do this, and not blow like all half of your R01 just getting the data to do your work. So I have a question, and this this is more maybe just clarification for me as well. But when you have the Millman data, so you're going to be working with them, and how do you get from that to perhaps saying we're going to look at individual hospitals and how they can utilize this score in their setting, sort of from this point to that point?
Yeah. So I mean, it's this first part is definitely expedited, like you said. So that's really exciting. I think that the next step, once we've done this kind of validity testing, is to look at a small scale. So I would think about doing a pilot study within another health system. Since I'm located in Louisiana, we'd probably look try to get at the barriers and facilitators to using this measure, because one thing that's exciting about it is that, like I had mentioned before, it can be turned into like a dashboard, right? That can be then use real-time data within the specific context. So we're using Medicare data, which may or not be available to a lot of health systems, but they can use their own clinical data to calculate the measure. And you could even use census data to bring in some other elements of it. So there's various ways that the measure can use multiple data sources to be calculated, which I think is really great that it has that flexibility. But I think after we can say, all right, we did this nationally, the measure shows this level of validity. Now let's start talking to health systems about implementation. And, how could you use this in your own work for quality improvement? Is this something that you'd want to see calculated on a yearly basis, or like a month, like Sutter Health did it on a monthly basis for their executive team? That's one aspect of like piloting and implementation. Then there's also, this is something that, CMS is really eager, I think, and many other, like payers are eager to have measures to kind of track improvement over time, more of like the health plan or payer level. And I think this is something that they could consider, routinely using to try to get at assessing equity on a national level or a state level. So I think there are many potential applications once we get past the validity stage. And what's great about this is that it'll be using national data, right? Hospitals, health systems across the country. So we can even potentially get at, what are the differences, say, by rural, urban, or, some of the other considerations that one might have when thinking about whether or not this measure might work in their particular context. So I think that there's a lot of potential projects, kind of implementation type projects that could come out of this to try to get this into people's hands as quickly as possible if it works.
Right, so. Which is critically important, right? There's a lot of discussion about implementing health equity in the healthcare system, but not enough discussion about how we measure that. And that's what's really great about your study. And I'm thinking, previously you mentioned there are other types of equity that you study in terms of LGBTQ populations or in disability. Do you think this is something that could lift from looking at racial and ethnic equity within the healthcare system to looking at other populations as well?
That's great question. Yeah, that's exactly the road I would want to go down with this. I think we can start with race and ethnicity data, because even though it's not super well collected nationally, it's a good starting point because there's more of a will to collect these data, and also it's available in the Medicare data. I read studies that have come out recently about the acceptability of collecting data on sexual orientation and identity and behaviors in healthcare settings, and it seems promising. So I think, you can kind of swap out any demographic characteristic into the measure, which again also speaks to its flexibility. And I would love to see, if we can, if we demonstrate that this has a high level of validity, that it be applied to other populations.
Okay, so maybe we could talk a little bit more about the higher, what you call the higher level discussion that was a little earlier in your proposal. Is something that I think about all the time, and I think maybe other people do too, is the question of studying health disparities versus studying health inequity. So you mentioned that you study health equity. Now, how would you distinguish the two for people who haven't thought about that very much? Because they're often used interchangeably, even in the literature. People will say one thing and the other, and then they kind of mush together. How would you distinguish those for people who don't think about it?
Yeah, I think multiple ways to probably distinguish it, but the clearest way, I think, is historically, health disparities research has focused on, and just thinking about one issue is the reference group. When we think about health disparities, especially racial and ethnic disparities, it usually centers white as the reference population, white people.
Right.
And often, as we, across many outcomes, white people may not have the best outcomes, right? So, and especially if you might be looking at rural populations or you're stratifying by socioeconomic status, and especially if you're not just comparing African American and white disparities. So more often than not, you'll see a gap there, but for Asian Americans, Pacific Islanders, you might see, better outcomes, right? So part of health equity, shifting to health equity, is decentering the whiteness part of it, like one element, and trying to identify targets that are a little bit more race agnostic, targets that we think everyone should be able to reach in order for us to have a healthier society. And in the case of looking at hospitalizations related to heart failure, we might want to have a better expectations for our health system than what the current white hospitalization rate is. So part of it is decentering that, and that is paradigm shifting in some ways. And there is some disagreement also within the community when you kind of get down to the meat and potatoes of it. It's, some people might say, no, we need to continue to measure these gaps between white and black and white, and I think it's both, because we kind of want to know what that gap is, but we want to set a higher standard for everyone. So I think that's one of the easier ways to conceptualize the difference. It's also framed in a more positive way, right? So we're trying to help people live the healthiest lives possible and not just, close a gap, right, between these individual groups. That changes over time and is more can be a little arbitrary, even in how race is categorized. So, but the considerations change depending on the population that you're talking about.
Okay. Yeah, well, thank you for that. I think it's really important to think about, improving the healthcare system in a positive way. Disparities in and of itself is really thinking about the negative difference between groups, and not so much thinking about how everyone can get to a, like you say, a better outcome for all. So in doing this work, which I again think is, I'm really glad that, that working with Millman is going to be, of great benefit to your work and kind of speed things along. So how do you plan on, for lack of a better term, getting the word out? If you validated your measure and you find that it actually is doing what you intend for it to do, there's kind of a space between perhaps even saying you've published it, in the journal, getting from that place to having it implemented in, real healthcare settings. Sort of how do you bridge the gap between those?
Yeah, like you said, obviously the first step is, having our peers take a look at it and put it in a publication. But I think we talked a bit about a dissemination plan, which is we need to put this in more plain language for the people who are actually going to use the measure. So, their outlet, Health Affairs, is a really great outlet for, that actual real people read. So it's like that type of, looking for outlets like that. But I think we also need to be more creative, social media, and getting it in, targeted, looking for getting it in front of the right people. And I have quite a long list. And this is where I think it's been really helpful, working in the kind of quality measurement enterprise before coming into an academic setting, which can be a little siloed. Getting it in front of the people at the Center for Medicare and Medicaid Innovation, or, you know, the Center for Clinical and Quality Standards, getting it in front of the right person at the AMA or the AAMC. You know, I think, you know, and that type of targeted outreach, just so that they can even be aware that, you know, this work has been done, and, you know, maybe potentially invested in seeing it moving forward. I think that's kind of like the right level of targeting. That would be great. And so, like, you know, maybe writing up, like you said, some sort of a white paper that can be easily shared with all of these different key stakeholders would be a great way to you know, a great next step, aside from it just, you know, ending up in a publication. So I think manuscripts, white paper / blog, and then targeted outreach.
Okay. Yeah, and I think, you know, one of the partners we work with, Academy Health, I mean, they obviously they're responsible for, you know, health affairs, but one of the plans that we have too, and we want to be supportive in any way that we can to kind of help bridge that gap between sort of peer-reviewed manuscript, which, you know, as we all know, can have a very small number of eyes on it, to getting that larger audience. And so, you know, as we go through this process, if there's anything that PTEC can help with, and, you know, you already know a lot of the people, but if there's anything that we can help with, that maybe you don't have a lot of time to, you know, do that outreach, to get that in front, like you say, in front of the right eyes, because I think that this is something that a lot of stakeholders are looking for, even if they don't really know that they're looking for it, looking for sort of a way to quantify the effort that's being put into health equity initiatives. And so I'm really glad that you kind of brought this to our attention, and that we can, you know, we were able to fund it. And I'm really looking forward to seeing what comes out of the work. So again, I'd like to thank you for joining us. This is Andrew Anderson from Tulane University, and we will be keeping track of all of our grantees. And so we probably will do interviews again in the future. So, you know, again, really happy that working with Millman will just accelerate your work beyond what you might have been able to do. And that's really PTEC's goal with this, is to move beyond descriptive research to getting really implementable solutions. So thank you for joining me. And well, we'll talk again soon.
Yes, I appreciate it. Thank you for having me and having this conversation, and really appreciate you all taking on this really important initiative and funding this work.
Okay. All right. Bye.
Bye.